All right, the 2026 ADA Standards of Care are out, and wow, are they packed with some big updates. Now, let's be honest, as a busy clinician, who has time to sift through hundreds of pages? That's exactly why we're here. In this breakdown, we're going to cut right to the chase and focus only on the most impactful, practice-changing revisions you really need to know about. And it's not just us saying it's urgent. The ADA's own professional practice committee puts it perfectly. The pace of change in diabetes care is just accelerating like crazy. We're not talking about small, incremental tweaks anymore. The new research, the tech, the treatments, they are literally reshaping the entire landscape of diabetes management. So yeah, this is way more than just another annual update. It's a snapshot of a field that's evolving at lightning speed. So, our goal here is simple: to boil down all that dense guidance into the absolute must-know, practice-altering takeaways. We're going to zero in on what's new, what's different, and, most importantly, what this actually means for the decisions you'll be making in your clinic starting, well, tomorrow. Okay, so before we dive into the specifics of drugs and tech, let's pull back for a second and look at the big picture. Because honestly, one of the clearest messages coming out of the 2026 standards is this huge philosophical shift. It's all about a more multidisciplinary, more collaborative approach to care. And you can see that shift right here. I mean, look at this. These endorsements aren't just logos slapped on a document. Having the National Kidney Foundation and the International Society for Pediatric and Adolescent Diabetes on board for the first time, that's a huge signal. It's the ADA basically saying, hey, diabetes care is a team sport. It's not just an endo thing anymore. It's deeply woven into nephrology, cardiology, pediatrics, you name it. All right, let's move on to what is arguably one of the biggest shifts in these new guidelines. We're talking about technology. Because tech is no longer this nice-to-have add-on. The 2026 standards have planted a flag, making it a core, foundational part of how we should be managing diabetes today.
And this right here is a perfect example. This is a game changer for clinical practice. We're talking about continuous glucose monitoring, or CGM. The recommendation now, it's to start it right at the beginning, at diagnosis, for pretty much anyone on insulin. We're flipping the script from being reactive to being proactive. Having that rich data from day one is now the standard of care, not the exception.
And to make all of this a bit easier, the ADA has also cleaned up the language around CGM. You know that old term, intermittently scanned? Well, it's pretty much being phased out. Now we have these three really straightforward categories: real-time CGM, the new over-the-counter option, which is going to be huge for access, and professional CGM for our diagnostic work. It just makes the whole conversation, whether it's with patients or other clinicians, so much clearer.
And the tech-forward approach doesn't stop with CGM. This is huge. For individuals with type 1 diabetes, and for many with type 2 who are on intensive insulin therapy, automated insulin delivery, or AID systems, are now considered the preferred method of insulin delivery. It's not just an option anymore. The guidance is crystal clear. We should be offering this to everyone who's a good candidate.
Okay, let's switch gears and talk about pharmacology, because the whole paradigm has shifted. For years, it was all about the A1C, right? Lower the A1C. Well, now the focus has broadened dramatically. We're thinking just as much about actively protecting vital organs: the heart, the kidneys, the liver. And these four drug classes you see here, they are really at the center of this new strategy. The guidelines are now structured around choosing these agents, not just because they lower glucose, but because they have these proven powerful benefits for managing and even preventing major comorbidities. It's all about that dual benefit.
So what does that actually look like in the clinic? Well, take a look. For a patient with symptomatic HFpEF, we're now recommending GIP/GLP-1s or GLP-1s to reduce events. For CKD, the guidance is now to consider starting an SGLT2 inhibitor and an NSMRA right alongside a RAS inhibitor, simultaneously. And for liver disease, specifically MASH, GLP-1s are now the preferred therapy for glycemic management. It's incredibly targeted organ protective care.
And this whole proactive mindset doesn't just apply to treatment. It's also reshaping how we think about diagnosis and prevention. The new guidelines are really pushing us to sharpen our focus on catching things way earlier, whether that's pre-symptomatic type 1 or even heading off complications from other therapies.
Here's a subtle but really important refinement for early diagnosis of type 1. We're now being urged to evaluate anyone promptly if they have even one islet autoantibody. But here's the key part. The guidance specifically calls out that a single IA2 autoantibody carries a risk of progression that's pretty much the same as having multiple autoantibodies. So what does that mean for us? It means we need to monitor these individuals just as closely.
And check this out, a super practical brand new protocol. With more PI3K alpha inhibitors being used in oncology, we're seeing more hyperglycemia. So now we have a clear 3-step playbook. Step 1, counsel the patient on the risk before they even start. Step 2, monitor them closely, especially in those first few weeks. And Step 3, actually consider using metformin preventatively. It's a perfect, actionable example of that collaborative care between endo and oncology we were talking about.
All right, let's do a quick, rapid-fire round on some key changes for specific populations. Because one thing's for sure, the guidance is getting way more nuanced and tailored to the individual.
First up, older adults. And the big theme here is really about simplification. The goal is to boost safety and efficacy by reducing the burden of treatment while still getting great outcomes.
So what are the top 3 takeaways for this group? Number 1, CGM is now specifically recommended for older adults on insulin to help cut down on hypoglycemia. Number 2, our blood pressure goals are getting more flexible. We can and should relax that target for patients with poor health or limited life expectancy. And number 3, there's a whole new framework to help guide us on when and how to de-intensify or simplify treatment based on their functional status. Super helpful.
Okay, next up, kids and adolescents. The whole pediatric section got a major overhaul. And the biggest change is that it now does a much better job of separating the guidance for type 1 and type 2. Because as we all know, those are 2 very different diseases with very different paths in our younger patients.
So, a few key highlights for pediatrics. First, the medication section is now updated with the latest data on using GLP-1s, SGLT2s, and the dual agonists in kids. Second, there's a much stronger push for creating formal, structured programs to transition adolescents to adult care, which is so important. And finally, psychosocial screening for things like diabetes distress and anxiety is now recommended to begin as early as ages 7 to 8.
And what about pregnancy? The updates here really zero in on 2 key areas: being more proactive with preconception planning and tweaking some of those in-pregnancy management targets.
So what are the key takeaways for your practice? Well, there's brand new explicit guidance to discontinue GLP-1s and dual GIP/GLP-1 agonists before a patient tries to conceive. The blood pressure threshold for starting antihypertensives during pregnancy is now 140/90. And lastly, the discussion around using CGM in gestational diabetes has been updated to include the latest clinical trial data.
Okay, so if we pull it all together, you can really see the 2026 standards resting on 4 main pillars. 1, technology is not an add-on, it's foundational. 2, organ protection is now a primary reason we choose certain medications. 3, our care is becoming much more proactive with a big focus on early detection. And 4, the guidance is getting way more nuanced, with really specific, actionable advice for different patient groups.
And that really brings us to the final and most crucial point. Because at the end of the day, these guidelines are only as good as their application in our practices. So, as you think about everything we've just covered, the tech, the new drug strategies, the population-specific care, the real question is the one right there on your screen. Which one of these changes is going to have the biggest impact on how you practice tomorrow? It's definitely something to think about.